Good morning, I'm Namrita. I'm presenting on behalf of Medicine 3. So my case is titled, Can You Crack This One 2 Plus? Ms. DT, a 35-year-old professional from Delhi, she presented with insidious onset dyspnea with anasarca, orthopnea, and paroxysmal nocturnal dyspnea for 6 months. She was at presentation. She was not known to be diabetic or hypertensive, and she had no siblings who were ill with cardiomyopathy. There was no recent history suggestive of infections that could cause a myocarditis. Examination, pulse was 88 per minute, regular and all peripheral pulses were present. Blood pressure was 110/70. She was obese, and there was bilateral pitting pedal edema noted up to the calf along with abdominal wall edema. Jugular venous pulsations were not elevated. There were no nodes, pallor or cyanosis. The apex beat was shifted downward and laterally at the sixth intercostal space, 2 centimeters lateral to the mid-clavicular line, and heart sounds were heard normally with no murmur. Other systems examination were unremarkable except for an abdominal wall edema that was present. Initial investigations revealed normal renal function, normal CKMB and TROP-T, negative blood-borne virus screen, slightly elevated 24-hour urine protein, and an echo showed severe LV systolic dysfunction, global hypokinesia of the LV with an ejection fraction of 25%, and an NT-proBNP was also elevated at 4,832 picograms per ml. So we were thinking what caused Ms. DT to develop heart failure at the age of 35. Some differentials that we thought of were genetic, dilated or familial cardiomyopathies, drugs or toxin related, myocarditis that was post-infectious or autoimmune, mitochondrial cardiomyopathies, ischemia related cardiomyopathy, sleep apnea, and congenital adult onset congenital heart diseases. So we went ahead with the cardiac MRI, which again showed mildly dilated LV with marked reduction in global systolic dysfunction. Overall, the features looked like there was some active myocarditis with features of chronic myocarditis superimposed on that. So while we were evaluating her for young onset heart failure, she developed certain necrotic skin lesions with subcutaneous induration, with severe pain and areas of necrosis over the calf region of her left leg. And subsequently, she started developing these lesions on the right leg as well. There was no associated fever. So this is what the lesions looked like. There is this central area of necrosis surrounded by this duskiness around it, and it's exquisitely tender. So tender that even movement of a bedsheet near her leg causes that much pain. And she started, this is the lesion on the left leg that she developed. She had a similar small lesion that was started developing on the right leg also. So any differentials as to what this might be? So initially we thought probably it's a perfusion problem. She has myonecrosis, so skin necrosis, probably a deep venous thrombi that has caused perforators in the skin to impair drainage from the perforators of the skin. Anyway, we investigated through these towards these in the beginning. CPK was normal. Doppler did not show any deep venous thrombi, only venous congestion. Skin necrosis was something we thought of, but she wasn't on any of the known offenders like warfarin. DIC parameters were normal. Septic emboli was also something we thought, but clinically she didn't have any other features of sepsis. Counts were normal. She was not febrile, tachycardic, no SIRS, but CRP had gone up from 28 that I showed earlier to 70. So we looked up and found that calciphylaxis is one of the things that present like this. This is on the left is the up-to-date picture for calciphylaxis. We can see that there is an area of necrosis surrounded by this dusky hue, and they are very tender. This is just the picture that I showed earlier from our patient to compare with one of the images that describe calciphylaxis. It's described as a necrotic ulcer with an eschar. This is early calciphylaxis. Later on, it progresses to frank calciphylaxis. This is a picture of a person, representative image with a person with end-stage renal disease that causes violaceous lesions and black leathery eschar-like lesions. So other differentials we thought, other differentials for calciphylaxis were retiform purpura that are associated with superficial calciphylaxis, small vessel vasculitis, cryoglobulinemia, prothrombotic states like APLA, oxalate vasculopathy, cholesterol embolization, and angioendotheliosis. We went ahead and biopsied this lesion on the left leg, which was showing epidermal necrosis with coagulopathic changes, basically thrombi in the blood vessels, paniculitic vasculitis, and some gram-positive cocci in the panniculus. At this time, there was no evidence of medium vessel vasculitis. But she went on to develop worsening paniculi, very tender, large paniculi over the legs and abdominal wall while admitted. So we biopsied one of these abdominal wall paniculi, which showed calciphylaxis with coagulopathic changes, atherosclerosis, and small vessel vasculitis. So just to summarize, this was a 35-year-old previously well woman, obese, with heart failure, and clinically she had paniculitis with skin necrosis. What we found from our evaluation was a probable small vessel vasculitis, calciphylaxis, and paniculitis. We were trying to tie heart failure with paniculitis and these skin changes. So one of the major differentials we thought of was a systemic vasculitis, small or medium vessel with a vasculitis-induced cardiomyopathy and a probable non-uremic calciphylaxis. When we look at non-uremic calciphylaxis, one of the major things we have to look at is a hyperparathyroidism, and a high calcium level because of other causes like sarcoid, and vasculitis. So our workup we had done towards all this, everything was negative actually. Her PTH was normal, calcium and albumin, calcium and phosphate levels were unremarkable. Secondary vasculitis due to RF and rheumatoid disease and SLE, those workup was also negative. ANCAs were negative, cryoglobulins were negative. Complete prothrombotic workup is awaited, but APLA workup is negative. Her CRP kept going up from 28 to 70 to 178, and she was developing new paniculi, and this area of calciphylaxis was also extending. So in suspicion for a small or medium vessel vasculitis, we started oral steroids at 1 mg per kg prednisolone equivalent. Why not pulse steroid? Because she had a heart failure. We did not want to risk that fluid overload. So, and we began under antibiotic cover. We covered with linezolid for the GPC that we had found in the panniculus. She was actually supposed to do an FDG PET with CT angiography to delineate the level of vascular involvement, but she had personal constraints and she opted to continue the remainder of her treatment in her hometown. My learning point from this is about non-uremic calciphylaxis. So calciphylaxis is also called calcific uremic arteriolopathy. It's a potentially life-threatening condition where vascular calcification produces ulcerative skin lesions. It was first described in patients with ESRD, but increasingly it is being described even in patients who don't have a high urea level. It's characterized by insidious asymptomatic medial arteriolar vascular calcification, resulting in clinical manifestations like necrosis when vascular thrombosis happens. And the implicated pathway is the NF-kappa-B pathway. The most common underlying conditions associated with non-uremic calciphylaxis are hyperparathyroidism, neoplasms, alcoholic liver disease, and autoimmune disorders. This is a paper from JAMA Dermatology in 2019. This is actually a case series where they detected 16 cases in between 18 years in this University of Washington hospital, and most of them were women aged 22 to 87. All of them had skin ulceration. And they looked at, these were the clinical profiles. So we can see secondary hyperparathyroidism, atrial fibrillation, steroid use, SLE, malignancy, SLE, DVT, diabetes, SLE, AFib, diabetes with AFib, malignancy again. The common treatments that they used in this non-uremic calciphylaxis were intravenous sodium thiosulfate 3 times a week, cinacalcet, and antibiotics. Although the number of patients was small, the condition affected was the non-uremic calciphylaxis was seen to affect predominantly women, and predominantly women who are on anticoagulants for autoimmune or APLA. This is another case report actually from 2018. And this describes that non-uremic calciphylaxis usually presents as a painful skin lesion with a livedoid pattern progressing to necrosis with a black stellate eschar and surrounding purpura that heals poorly and frequently becomes infected. A cutaneous biopsy is crucial for this diagnosis as it can show tunica media calcification and areas of thrombosis, cutaneous ischemia, and paniculitis, pathognomic for calciphylaxis. This paper also put up these risk factors for non-uremic calciphylaxis, like a high PTH, malignancy, autoimmune disorders, alcoholic liver disease, and prothrombotic conditions, being some of them. So this is a systematic review on calciphylaxis. This is much older. This is from 2008, and actually this paper was described that the mortality rate in non-uremic calciphylaxis is very high, up to 52%, and sepsis was the most common cause of death. Their treatments that they used was basically wound care and sepsis control. It is to note that this paper that we found in JAMA earlier, their mortality rate was much lower. It was about 16% because they had used sodium thiosulfate for a lot of their patients. Sodium thiosulfate use is actually traditionally described in end-stage renal disease associated calciphylaxis, but they had gone ahead and used it even when renal functions were normal and there was no uremia. None of these people in this 2008 paper, none of them had used sodium thiosulfate, cinacalcet, or hyperbaric oxygen therapy, which is traditionally described for treatment of calcemic uremic arteriopathy. Thank you.
Thank you, Ramika. Are there any questions from the floor? This biopsy was very specific for a calciphylaxis, or was it just also there?
So as per this, definitely the second one, they had felt that calciphylaxis is without doubt because it was in the media that they were seeing calcification, and dystrophic calcification is one thing that we have to look at, but that doesn't cause end organ manifestations. Like dystrophic calcification usually does not cause skin necrosis and changes like that. The question is, did the vasculitis cause the calciphylaxis, or did the calciphylaxis cause a secondary small vessel vasculitis? That was in doubt. But because she had initially presented with a heart failure and this happened in the ward, we were thinking she had an underlying condition from before, and the calciphylaxis was secondary to a vasculitis, which is why we went ahead and treated with steroid.
ACE levels were
normal, yeah.
We don't have a follow-up on this patient. Where is she from?
She's from Calcutta, but she's from Delhi, but she's living in her parents' house in Calcutta.
Heavy metal screen, did we have a chance to do?
No, we didn't send. She didn't have history of Ayurvedic medicine intake, but yeah, we did not send heavy.